We're here at ANZUP's annual scientific meeting, Adelaide 2026. ANZUP in conversation with one of our esteemed international guests, Professor Sarah Sutka, from the Fred Hutch in Washington. Fantastic to have you here, Sarah. Thank you so much for coming.
Well, thank you so much for having me.
You just gave a tour de force presentation within our first session, What Matters Most. I wrote down about 15 questions. And I let the session go on too long because that was one of the most engaging sessions I've seen in a long time. Thank you so much.
Well, thank you for highlighting that as a key topic, asking patients, why are we all doing this? I think that as we start to think about designing clinical trials, we really have to challenge ourselves to start to re-litigate endpoints and ask what endpoints matter. I thought that Jared, who spoke before me, he made the point that it's the people who decide the endpoints that just sort of say what's important, that's where we really need to be ensured that the patient voice is a key part of that conversation.
There's an old saying that not everything that matters can be measured, and not everything you can measure actually matters. So how do we break through that? I mean, for example, we talked about the time burden of treatment and the financial burden of treatment. How do we really measure those really effectively so that we can really communicate those to patients in the future?
Well, I think that, so first is just having awareness that there are these very specific patient-centric endpoints, and we don't have to reinvent the wheel. A lot of these endpoints are actually relatively well characterized in other medical fields. So think about geriatrics, which I joke that I'm trying to become a geriatrician. But if we look at geriatrics, there are specific patient-reported outcomes that quantify these variables and these domains in validated ways. And we don't have to create new questionnaires. We can borrow. So financial toxicity is a key one. Time toxicity and treatment burden. We talked a lot about the work of being a patient. There are questionnaires that are validated that we can integrate into our clinical trials that are not terribly burdensome, that capture those domains. I've gotten really interested recently in this concept of life space, which is the domain of where a patient lives their life. And so, for example, we think about this as we're studying recovery trajectories after major urologic oncology surgeries. A patient has a radical cystectomy. When they get home in the first 3 months, what proportion of their time are they in their bed in the bathroom, the bed in the bathroom in the kitchen? How about going grocery shopping? How about traveling to see their grandkids in another state or another province? But that actually gives us some really quantitative data about the impact that the disease treatment had on the way that they are actually living. And that's what patients want to know. So you can actually measure these things. It just takes a little bit more work.
And it's different for every patient. Some people, they really prioritize not seeing me at all, as infrequent as possible, please. But other people do find reassurance and come into the clinic in person, rather than a blood test and a phone call.
Sure, absolutely. And I think, of course, the environment within which you provide care really might influences that quite a bit. I take care of patients in an area where we serve a 5-state region that's 1/3 of the U.S. landmass. And so some of my patients are traveling, like patients from Alaska that are coming down to see me for their cystectomy. They're traveling 12 plus hours for surgery and then have to get back. But if that patient has non-muscle invasive bladder cancer and they're coming for their BCG, then we're really talking about tremendous financial and time toxicity and treatment burden. So we really do have to think about, what is that work of being a patient look like, and try to characterize that. Because when the patients leave our office, we're blind to it, but they live that every single day. So characterizing that is actually really critical. And that actually influences whether or not a patient elects treatment A versus treatment B, if it means less time in the office or less time in the hospital. But if we don't measure it, we can't give patients that feedback in advance to help inform their data, their decision making.
I thought I was doing a good thing. We enabled BCG treatment for a person from Port Lincoln to come across, which is an 11-hour drive.
Yeah.
A 1.5 to 2-hour flight.
Yeah.
Alaska.
Unfortunately, our our cancer center is the major cancer center for a lot, where most of our patients are coming for the big surgeries. I would say we can often get patients intravesical therapy in some of the bigger cities, but frankly, the distance from remote areas of Alaska to Anchorage or Sitka or some of the big cities, it's actually the same distance to Seattle. It's just, we don't understand these, like how vast these distances are. So we have to think about how do we provide high quality care to all of these patients, and how do we do it and minimize the amount of burden that they're subject to. So that's where things like, you can be very thoughtful about it, but again, we need to actually understand what that looks like for the lived experience of having that disease.
There's a true parallel here in ANZUP. Dick and Hayne in WA and his fellow investigator Cynthia Hawkes.
Right.
They've pioneered these kinds of follow-ups across Western Australia, which is an enormous landmass as well.
Right.
But all of those decisions that patients face, the key thing that I took away from the talk was that limits on decision with rate. So getting to the end of it and going, that was the wrong choice.
Yeah.
And I was inspired by everything you said, but goodness, how are we going to, make sure we optimize, be assured that patients don't feel that you prevent that decision to regret with all of the treatment choices that you face?
I think the biggest part of it is actually ensuring that patients truly understand their decision making and felt like they were engaged in the decision making from the get-go. They felt like their voice and their priorities were heard. A big part of it is actually, again, that concept of eliciting priorities and then trying to match treatment to goals, because that goal concordance is really important. But if we're not really active in engaging patients in the decision making at the beginning, like I always worry when a patient's like, "Doc, just tell me what to do." Like, well, I can't. That's not okay, because my priorities, my risk tolerance is going to be naturally very different. And so actually, when a patient says that, I'm like, I use that as an opportunity to say, okay, well, let's backtrack. Let's talk about day-to-day living. Let's talk about what's important. And then, so it's making sure they're really informed and they truly understand in a transparent way what the potential implications of each treatment look like. But it's really understanding and trying to be very active in matching the treatment to the goal. And what's a successful outcome is going to be very different for different patients. You go back to the Freed study in terms of whether you would accept shorter survival for more functional survival. That whole idea of well-being, that idea of maintaining the health span as opposed to lifespan, I think that framing is really important. And it's letting patients know that it's okay for them to say, actually, what you think is important isn't important to me. This is what's important to me. And that's what I wanted. That's the target I want to fight for. So it's really engaged decision making, and it's informed and it's shared.
And yeah, we talked about that being a dynamic discussion with every patient.
Yeah.
But then how do we take those dynamic learnings and how we keep decision aids? We can't spend all this, all the time we want for every person. So we want decision aids. We want resources that we can offer to people up front, correct them so they can understand. How do we keep updating those decision aids in a dynamic way?
Well, it has to be dynamic because care is changing so much. We have treatment options today that we didn't have last year. Look at EV Pembro for perioperative care for muscle-invasive bladder cancer. Look at what's happening in the non-muscle invasive space. Look at adjuvant kidney cancer now escalating to include the HIF2 alpha inhibitors on top of Pembro. So unfortunately, this is a very fortunately, this is a very dynamic field. Unfortunately, it means that we need to keep up with it. So I think it actually, I guess the answer is we need to prioritize it as a really important scientific field of investigation. But I do really think there are implementation hacks that can allow us to use these tools without breaking the time bank in the clinic. So I send patients home with links to the Bladder Cancer Advocacy Network website, where there are decision tools and information that's validated and carefully vetted and that they can engage with. Our nursing teams and nurse navigators are trained in decision coaching, in eliciting priorities and having patients do that work before they come to clinic.
But before they even meet you?
Well, not necessarily, but before they come to clinic on that day. I mean, obviously, it has to be directed by the provider. But I think also just empowering patients to say, here are some tools that I think can be helpful. Take it home and work with it. And a lot of them are actually meant to be self-directed. They're not meant to be done with a DOM. So, it's education. It's ensuring that patients feel like they have some agency. Um, but it's also advancing the science of decision making, which is something that it's something I'm trying to learn about. I'm not an expert in it at all, but I think that it's just being aware that like we can do this better, and we should.
Absolutely. Listening to your talk, it's inspired me and doomed me. So we're certainly trying to do that.
Yeah.
But just to touch on those more neuropathies, we face this more and more where there are obvious and sensible commercial incentives to compare your new drug versus a previous standard of care,
Right.
but then not to compare your new drug versus everyone else's new drugs.
Yeah.
So when we face that kind of burden, how do we respond to that? And we've got these non-comparative, lack of comparative trials for these super novel agents.
Yeah, I mean, I gave the example of my conversation about BCG unresponsive non-muscle invasive bladder cancer. Now, I have to actually schedule that as a 30-minute visit as opposed to a 15-minute visit. 'Cause you can't do it in 15 minutes safely. And we don't have these. We're in the bed we made for ourselves. We accepted single arm studies that were the outcomes that would ultimately lead to registration were benchmarks that we as a community had decided were valid. But now we have this embarrassment of riches. We have all this data. We have all these different trials. You can't compare them cross-trial because they're different study populations. How do you help a patient choose between treatment A, B, C, D, E against cystectomy? So the truth is now that we have valid comparators, we have to mandate comparator arms because now we have equipoise. We have ethically appropriate and acceptable comparators, which is exciting. But the other thing is, I think as trialists, we need to be thinking about designing pragmatic trials when you can't randomize. And I said this, I think like the cysto trial is a really good example of that. You can statistically develop study designs that will help to get at those answers without the constraints of a formal randomized controlled trial. So a couple of different options. So one, you develop pragmatic trials where you're not actually randomizing patients in an artificial sort of manner, and you let patients choose the treatment, and then you evaluate their outcomes and you use statistical modeling to help to try to start to balance cohorts. I think you can do that. It's not perfect, but it's really relevant in terms of a real world data set. You can also engage patients in trial design, which ANZUP does so well, and which we try to do because having that stakeholder engagement from the get-go, from the grant writing, from the trial design is so critical to ensure that a trial is going to be successful. Patients will vote with their feet. They're not going to sign on to a trial that they don't think is ethically appropriate. But then there's also the rule for real-world data and phase 4 studies. And I'm currently engaged in a couple of these extended access programs where we actually have integrated these patient-centric endpoints into the data that's being collected because the primary endpoint is no longer efficacy. The efficacy is there. The drugs are either on fast track approval for FDA approval or on the fast track designation for FDA approval, or they've already been approved. And we're trying to understand in a real world setting, what is the safety? What is the treatment burden? What is its impact on time toxicity and financial toxicity? And then using that data to inform our counseling. So I think there's a lot of ways that we can get around it. It's also accepting the murkiness of it and the human nature of it, and being honest about what we know and what we don't know.
Yeah, there's been some drives in extraordinary circumstances. When we first had ipilimumab in Australia,
Sure.
it had a conditioning set of extra requirements like listed because obviously it was a novel therapy with substantial costs. And the reimbursement agency said that we're really going to need you to prove that it's as good as you say you said it was. Does that something that's now to have to become routine for all of the ANGs? There's going to have to be that proof. I don't know, some jurisdictions in Europe will actually demand that post-marketing data and say, yeah, in the real world, this drug is as good as you said it was on the label when they first when they first birth it. Do you think that's necessary?
It's a really good question. I kind of do. Um, I don't know. I guess it's going to be determined. So why is it necessary? Is it necessary for registration in different countries, different health economies? I can see where that would be helpful, and especially if you're in, a, for example, a healthcare system that really does value and integrate cost considerations in treatment registration. But actually, I think real world safety data and real world quality of life data is going to be different from trial data,
Mm.
the trial outcomes, because the patients who get on trial, of course, are not necessarily representative of the patients whom we're treating. And so, if you're actually trying to understand if you can generalize outcomes to the person who's sitting in front of you and they never would have made it onto the trial because their performance status simply isn't good enough, well, then that data becomes really helpful.
Mm.
So, I think that we as a community probably need to prioritize collection of that data because it's going to help us counsel our patients better. But again, and it's great when companies are funding those studies and really saying, okay, let's actually see how this drug performs in post registrational sort of marketing. Um, I'm engaged right now with J&J on a study called Novastar that's looking at the GEM-IDRS in the post-approval space. And the same thing with cretostimogene, CG Oncology's product that has fast-track designation with the FDA, but it's not yet FDA approved. We're looking at how that performs in an extended access program for patients with BCG unresponsive non-muscle invasive bladder cancer. And I really commend those companies for saying, yeah, this is a priority. We actually need to understand how this works. So I, I think it's important data. And we as a community should continue to kind of really ask ourselves, is this measuring up? Does this data in the real world look like what we saw in the phase 3 trial? Because that's how we actually can counsel our patients more effectively.
Absolutely. One of the canonical examples was just one of the Antanix great gifts to the world is to run studies straight after the original docetaxel trial in prostate cancer, and to look at the next 150 people who came through a major cancer center, but just my group, and to look at their outcomes. They weren't trial patients, and the toxicity was high, and efficacy was possibly understood.
Because it's the real world
It's the real world, yeah.
versus a trial.
And I understand the people who say, you know, real world data is not the level 1 evidence. But you do have to understand, you do have to actually have a viewpoint on how these drugs perform in the patients in whom they are meant to treat. And that's where this whole the idea of like construct validity is super important when we think about trial design. I think about this in the exercise trials that we design. You know, we looked early on with my team at some of the exercise trials that had been the early GU exercise trials, the prehab trials, and they just weren't hitting their marks in a lot of cases. And it's because I think we summarized some of the sort of knowledge gaps, but a big one was this idea of construct validity, where people were trying to use like high intensity interval training for our radical cystectomy population. So if you're taking a patient population with a median age of 73, who have a 70% sarcopenia prevalence, and you know, the vast majority of patients have 8+ major comorbidities, and then you're asking them to flip tires, that probably isn't the right approach. But what we do need to think about is how do we design trials that are directly relevant for the patient population that we actually need to take care of at the end of the day. So I think that, you know, it's really important that we understand how these new agents perform in real world settings. And another great example of this is actually just look at the new data from like Potomac and Crest and the studies that are looking at adding checkpoint inhibition to the BCG naive space, the toxicity profile, and understanding, for example, how that plays out in the real world setting. But the sort of, I guess one of the big lessons that I took away from those trials was actually not even just what the efficacy was when you escalated therapy. It's actually how well the BCG only arms did.
Mm-hmm.
Because when you actually give people real BCG with maintenance, you get a 3-year, 70% disease-free survival rate. all of a sudden you're like, oh, this is the benefit of a trial. And it does change outcomes compared to real world practice, where we can't get maintenance, we can't give people full dose, we can't follow patients as well. There's loss to follow up, things like that. So that's the tensions of extrapolating trial data to real world practice, and why we have to actually collect real world data.
Yeah. Well, look, those were questions just from your 20-minute talk that you've just given, but another one this afternoon.
We're jumping off.
But are you able to talk about your RO1?
Oh,
Are you allowed to speak?
I can. Yeah, I'm going to highlight that this afternoon,
Yeah,
actually.
thank you. Well, look, that we speak directly to that really practical possibility that BCGs for non-muscle invasive bladder cancer is incredibly effective, but sometimes are a very difficult treatment for people to tolerate.
Yeah, absolutely.
You've got your first RO1.
Yeah,
And so-
we're waiting. We just got our IRB approval, so we're waiting on the NOA, but we've been told that it's going to be funded.
Yeah.
So,
Yeah.
for a long time, I've been interested in trying to figure out how do we decrease the toxicity of all the therapies that we are asking patients to go through. And I have a really amazing integrative oncology team at the Hutch. So about 7 years ago now, I had coffee with the head, and I was asking, her name's Heather Greenlee. She's an amazing PhD in nutrition and integrative oncology. And I was asking her about whether or not she's ever used her acupuncture, which is often used for overactive bladder, to manage bladder cancer, intravesical therapy related toxicity. I mean, she hadn't. So we started just building a protocol where you could actually use the acupoints that have been used to manage overactive bladder and overall health and wellness in the OAB space. And that's where like P10s, the peripheral tibial nerve stimulator, like the science behind all of that is based on acupoints. So we just got creative, and her acupuncturist developed a protocol which was basically meant to mitigate lower urinary tract symptoms. And we ran a pilot, which we rapidly accrued in our clinic, where we gave patients BCG in clinic, or we gave patients acupuncture in clinic in the time between they're waiting for their urine dip to result and when they get their BCG therapy. So it's 35 minutes. And it was a randomized controlled trial. We were trying to prove safety and efficacy, and that it wouldn't just break our clinic. What was interesting was that it was safe, it was feasible, totally doable. Patients adored it. And we weren't powered for efficacy at all. It was a 45-person study, but there was an efficacy signal. There was a statistically significant decrease in lower urinary tract symptoms and bladder pain in the patients who got BCG compared to those who were getting usual care. So we've been working on this idea for a couple of years, and we just found out that we've got funding now to run a multi-center phase 3, which I'm really excited about. And so it'll be a 3-arm trial. We're going to look at this specific directed acupuncture intervention, so true acupuncture, but we're going to compare it to sham acupuncture as well as an attention weightless control. So people who are just in the trial getting wrapped in warm blankets for 35 minutes and sort of taking a nap before their BCG, which is kind of lovely to really understand like how much of this is just placebo, because it may be a lot of that. But
there's a proper randomized study.
But it's a randomized study
with a proper blinded control.
And the endpoints, the primary endpoint is change in bladder symptoms. But we're looking at all the health-related quality of life. And then we're also going to look at recurrence rates, because if that actually helps patients stay on therapy, you might hypothesize that it would improve recurrence-free survival.
What an interesting idea. Yeah.
Right?
Yeah.
But it's a non-pharmacologic therapy that is generally very well tolerated, that also will hopefully maybe improve the experience of going through what is otherwise a very noxious treatment. So anyhow, we're excited. It's going to be the next 7 years of my life, but I'm really excited to run this study. And I'm grateful for the opportunity to do it.
Tips for people who are trying to do these kinds of really patient-focused, but necessarily commercially,
Viable at all.
I'm actually important. So what top 10 tips, top 2 tips?
1, don't give up.
Yeah.
Everyone told me that none of this stuff, or not everyone, but a lot of people said, I don't believe it, the exercise stuff, which I feel like I'm so happy to be here. I feel like exercise has been mentioned in every single one of the sessions so far. I'm obviously very excited about using exercise to help our patients live better through their cancer treatment. But, prioritizing these really patient-centric sort of interventions and listening to patients. The ideas for these trials came from people who have the disease when they were saying, listen, is there anything else I can do that's not going to be me taking another pill that's going to make my mouth dry or make me confused, make me not feel great? And then it's actually getting really creative with funding. So we are fortunate that this study will be funded by the NIH, but a lot of our early studies have been funded by foundations and patient advocacy groups. I'm so grateful to organizations like Beacon and the Heal Care Foundation who have kind of stood behind these ideas and said, yeah, those were important. Let's look into those. Because they're not easy to fund, and obviously they're not necessarily commercially viable. They're not going to make anybody a lot of money. But man, oh man, if we can help people kind of live better as they're going through, make people fitter as they're going through their cancer care, gosh, wouldn't that be fun?
Persistence.
Yeah.
Patient engagement.
Totally.
Right.
Stakeholder engagement, right?
And then looking for funding under every rock, not
Yeah.
just this traditional.
It's the side hustle, right? It's all about just being super, super creative. And actually, the last one, which is actually more important, is you do it as a team, right? Because I'm just the doc who's recruiting the patients and bringing the people in, but my team, you'll see a photo in my afternoon talk of my exercise team. It's sports med, physical medicine and rehab, physiotherapists, a huge engineering team who runs all of our digital health intervention sort of management, the statisticians, the patients who actually, tried out all the exercises to make sure that they could do them. Our 86-year-old ladies with cystectomies who are doing planks and doing squats and showing us that they can do it. So it's building the team. I kind of think of myself more as a node that just kind of brings people together and tries to bring ideas into our field. It's definitely not me doing it. It's all of us. So team science too. There's the last one, team science.
Team science.
Team science all the way.
Professor Sarah Suka, thank you so much for talking with us with ANZUP in Conversation.
For having me.
You're at the ASM in Adelaide, 2026.